Hello everyone, and welcome to today's presentation. I'm excited to be here with you to discuss an important topic, Polycythemia vera. On this first slide, you'll see the title, which highlights the focus of our session. Throughout this presentation, we'll explore what Polycythemia vera is, its symptoms, diagnosis, and treatment options. So let's dive in and learn more about this condition together. Let's consider a clinical scenario that highlights some key features of a hematologic condition. We have a 62-year-old man who comes to the clinic with complaints of persistent headaches and facial redness. These symptoms can sometimes be subtle, but are quite telling. After taking hot showers, he notices intense itching, which might seem minor but is actually a significant clue. He also reports burning pain and redness in his feet, which suggests some circulatory or vascular involvement. When we examine him physically, his spleen is palpable, indicating it might be enlarged, possibly due to increased blood cell production or other underlying processes. Looking at his lab results, his hemoglobin is 19 grams per deciliter, and his hematocrit is 58%, both notably high. These values point toward an increased concentration of red blood cells, which is important to recognize. Putting all these pieces together, the symptoms, physical findings, and lab results, raises a strong suspicion for polycythemia vera, a myeloproliferative disorder characterized by excessive red blood cell production. Throughout the presentation, we'll explore why this diagnosis fits and discuss its implications. Let's delve into the pathophysiology of this condition. It's classified as a clonal myeloproliferative neoplasm, meaning it originates from a single abnormal stem cell that proliferates excessively. A key genetic feature here is the JAK2 mutation, specifically V617F or exon 12 mutations. This mutation causes constitutive tyrosine kinase activity, which essentially means the enzyme is permanently turned on, driving unchecked cell growth. As a result, we see an increase in red blood cell mass, which is a hallmark of this disorder. Often, there's also an elevation in white blood cells and platelets, reflecting the broad impact on the blood cell lines. Interestingly, despite this overproduction, serum erythropoietin levels tend to be low because the body recognizes the excess red blood cells and reduces erythropoietin production accordingly. Understanding this pathway is crucial because it explains the clinical features and guides targeted therapy options. It also highlights how a single mutation can disrupt normal hematopoiesis and lead to these characteristic blood abnormalities. Let's take a closer look at the clinical features associated with this condition. One of the most prominent signs is hyperviscosity, which can cause symptoms like headaches, dizziness, and visual disturbances. These occur because the blood becomes thicker and flows less easily, affecting oxygen delivery to the brain and eyes. Another interesting feature is aquagenic pruritus, which is intense itching that happens after hot showers. It's quite characteristic and can be quite bothersome for patients. Then there's erythromelalgia, where patients experience burning pain and redness, particularly in the extremities like the hands and feet. It's often triggered by warmth or exercise and can be quite debilitating. You might also notice a plethora, which is a ruddy or flushed complexion, another sign of increased blood volume or flow. Splenomegaly, or an enlarged spleen, is also common and can sometimes be palpable on examination. Finally, we need to be aware of the increased risk of thrombosis, both arterial and venous. This means blood clots can form more easily, leading to serious complications like strokes or deep vein thrombosis. Understanding these features helps us connect the clinical presentation to underlying pathophysiology, emphasizing the importance of early detection and management. Let's talk about diagnosis. The major criteria include an increase in hemoglobin or hematocrit levels, which indicates an elevated red blood cell mass. Additionally, bone marrow examination typically shows panmyelosis, meaning an increase across all myeloid lineages. The presence of the JAK2 mutation is also a key marker here. On the minor side, a low serum erythropoietin level can support the diagnosis, as it's often suppressed in conditions like polycythemia vera. The WHO 2016 criteria combine these factors: lab findings, bone marrow results, and genetic mutation status to make a definitive diagnosis. These criteria help us accurately identify the disease and distinguish it from other similar conditions. Understanding these diagnostic points is crucial, as they guide our management and ensure we're treating the right condition effectively. Now, let's discuss management strategies for this condition. First, we have risk stratification, which is crucial for tailoring treatment. For patients considered low risk, meaning they are under 60 years old and haven't experienced any thrombosis, we typically start with phlebotomy to keep the hematocrit below 45%, along with low-dose aspirin to help prevent clot formation. On the other hand, high-risk patients, those who are 60 or older or have a history of thrombosis, require a more aggressive approach. In addition to phlebotomy and aspirin, we add cytoreduction therapy to control cell counts more effectively and reduce the risk of complications. When it comes to cytoreduction options, hydroxyurea is our first-line treatment because it's been proven effective and well-tolerated in many cases. For younger patients or pregnant women, interferon is often preferred since it's safer during pregnancy. If a patient cannot tolerate hydroxyurea, or if they become resistant to it, we might consider ruxolitinib, which is a JAK inhibitor that can help control disease activity when other options aren't suitable. Overall, this approach aims to balance the risks and benefits, tailoring treatment to each patient's specific risk profile and circumstances. Let's talk about some important caveats related to treatment. Starting with phlebotomy, while it's a common approach, we need to be mindful of the risk of iron deficiency that can sometimes develop. Moving on to hydroxyurea, it's effective but can cause cytopenias, which means reductions in blood cell counts, and it may also lead to mucocutaneous side effects, as well as teratogenic risks, so pregnancy considerations are important. With interferon, patients might experience flu-like symptoms and psychiatric effects, so monitoring and managing these is crucial for patient comfort and safety. Ruxolitinib, on the other hand, can increase the risk of infections and also cause cytopenias, so vigilance is necessary during treatment. Finally, an important point to remember is to avoid routine iron replacement unless specifically indicated. Overall, understanding these caveats helps us tailor treatments more safely and effectively for each patient, aligning with our goal of personalized care. Let's walk through the creative mnemonic JRED River, which is a helpful way to remember key aspects of managing polycythemia vera. Starting with J, that stands for the JAK2 mutation, which is a common genetic marker we look for in diagnosis. Moving to R, it reminds us that patients often have an increase in red blood cells, leading to thicker blood. E stands for low erythropoietin levels, which is typical in polycythemia vera and helps differentiate it from other causes of erythrocytosis. D highlights the danger of thrombosis and splenomegaly because these are significant complications that we need to monitor and prevent. Now, the river part of the mnemonic is especially useful because it summarizes our management strategies. Reducing hematocrit below 45% through phlebotomy is a key step. For younger patients or pregnant women, we might consider interferon therapy. Vigilant use of aspirin helps prevent blood clots, and we also need to watch for symptoms like erythromelalgia and pruritus, which can be quite bothersome for patients. Finally, regular reassessment is crucial to adjust treatment as needed. Overall, this mnemonic ties together the key diagnostic features and management principles, helping us stay organized and focused on preventing serious complications while improving patient quality of life. All right, for this final slide, let's go over some important exam and practice notes. When evaluating suspected cases, look for the hallmarks such as a positive JAK2 mutation, which is a key marker. You'll also want to note low EPO levels, which support the diagnosis. Patients often experience aquagenic pruritus, meaning intense itching after contact with water, and erythromelalgia, a burning pain and redness in the extremities. One of the most critical points to remember is maintaining the hematocrit below 45%. Keeping the HCT under this level significantly reduces the risk of thrombosis, which is a major complication. For patients classified as high risk, the first-line treatment is hydroxyurea. This medication helps control blood cell production and reduces the risk of clotting events. By understanding these hallmarks and management strategies, we're better equipped to diagnose and treat these patients effectively, ultimately improving their outcomes.